The eye sees, perceives, looks, understands. But the eye also knows how to smile, laugh, cry. It's by studying the eye, its richness and complexities, that Santen has continued to develop and sell for the past 120 years innovative treatments to preserve this precious organ. In today's world dominated by technology, the eye has never been so essential. At Santen, we are committed every day to improving the quality of a patient's sight, thus improving their quality of life. Thanks to ever more effective solutions for treating ophthalmic conditions, we ensure a brighter future in ophthalmology. Born in Japan, we develop our expertise for the benefit of patients and physicians around the world. Our philosophy, our clear vision, exploring the secrets and mechanisms of nature in order to contribute to people's health. Santen, a clear vision for life.
Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tafloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tafloprost brings you the power of quality IOP control.
Good evening, everyone, and welcome to the PGS Glaucoma Roadshow. I am Tori Yao Rosario, and I will serve as your moderator for tonight. This is the last of a series of lectures for the PGS Glaucoma Roadshow. We have tackled basic concepts in glaucoma from perimetry, gonioscopy, medical management, and tonight we will be discussing about laser treatment. These topics are essential not only for the residents in training, but also for general ophthalmologists who are in practice. These sessions are being broadcasted in 2 different platforms via PGS Webinars Facebook page and through the PGS YouTube page. So for those who may not be able to watch this live, this lecture will still be available for them to watch at their own convenience. Of course, this event would not have been possible without the generosity of our sponsor for this evening, Santen Philippines. So first and foremost, I would like to call on our PGS President, Dr. Manolet Delfin, for the opening remarks. Sir?
Thank you very much, Tori. And good evening, dear colleagues. Thank you for joining us again tonight, the last in our series of webinars for the general ophthalmologist and the residents and fellows. These lectures were on the basics of glaucoma were developed by the members of the PGS and were delivered by various members during the road shows before the pre-pandemic era, which seems so long ago. These lectures will be improved and are updated regularly, and we are in the process of developing our next series of webinars on topics that have not been discussed. If you have any suggestions or any topics you want to be discussed in our future webinars, feel free to send us a message. And for the benefit of everyone, these lectures will be uploaded in the PGS YouTube page for those who wish to replay or rewatch these lectures. Today, our members from in PGS from Ilocos will be presenting for you. Tori is our moderator and June will be our speaker. And once the basics of these lectures have been delivered and uploaded, we then plan to hold more personal discussions with our colleagues in all parts of the Philippines regarding their cases and their difficulties in the management of glaucoma. If you have difficult cases or management dilemmas in glaucoma, please feel free to call us or to let us know, and we can arrange our virtual meetings with your group or with your chapter society to help you all. I would like to thank all the PGS members and the PGS board for their support in this endeavor. Thank you to Dr. Happy de Guzman for spearheading this project. And thanks to the PGS technical team headed by Dr. Rainier Covar and Dr. Cesar Perez. And our new members, Dr. Jet Riel and Dr. Paul Gomez. Thank you also to our recent glaucoma fellow graduate, Dr. Ruel Villanueva. Thank you especially to our sponsor for tonight, Santen Philippines, headed by Jennifer Ramirez. Thank you very much for your continued support for PGS. And thank you for your continued support and hopefully upcoming support for our next webinars. Again, thank you very much for joining us, and we hope you learn a lot from this lecture. Thank you, and back to you, Tori. Thank you, and good evening.
Thank you, Dr. Delphine. Let me remind everyone to please fill out the feedback forms posted in the YouTube and Facebook chat boxes. This will serve as your attendance for this session. If you have questions during or after the lecture, please post them in the chat boxes in the platform you are watching from. So to get things started, let me call in Dr. Polly Chow to introduce our speaker.
Thank you, Tori. Good evening, everyone. Tonight, it is with great pleasure that I introduce our speaker, who is a very well-respected ophthalmologist in our field, as well as a very good friend of mine. He completed his medical degree in University of Santo Tomas, then finished off his ophthalmology residency at St. Luke's Medical Center, after which he trained as a clinical fellow in glaucoma at the prestigious Western Sydney Eye Hospital in Westmead, Australia. Currently, he practices at his hometown in Lawag, Ilocos Norte, and is an active consultant at Mariano Marcos Memorial Hospital and the Black Nazarene Hospital. In addition, he's also affiliated with St. Luke's Medical Center. So without further ado, please welcome Dr. Justo Manuel Orros.
Hi, thank you. Hello, thank you everyone, and good evening. So let me just share my screen now. Share screen. Okay. Okay, so welcome to the PGS Glaucoma Roadshow, and this is the fourth lecture of the series, and I'm going to give you a short talk about lasers in glaucoma. These are the objectives for this evening. Now, lasers have been around since the 1960s, and we have been using them for diagnostics and treatment for various diseases. There are many types, but the introduction of the argon laser forever changed how we manage certain ocular diseases, including glaucoma. Now, these are the properties of lasers that make them useful for us. These characteristics allow for high energy to be focused at a very specific area or areas in the eye, sometimes even penetrating through tissues to produce its effect. be it an incision, coagulation, cauterization, or any other physical change required for the treatment. Living or organic tissues interact with high energy in different ways. The energy can be absorbed, which in turn produces an effect on the tissue. It can be transmitted, which allows tissues underneath the first layer to receive the effect. The energy can be scattered within the same tissue to affect the areas beside the point of contact with the laser, and the energy can also be reflected back. The type of laser and type of tissue will determine the outcome of laser energy applications. These are some of the effects of lasers onto living or organic tissues. For ophthalmology, specifically glaucoma, we will concentrate on thermal effects, which produce coagulation, cauterization, and reprofiling of tissues, and ionizing effects, which produce incisions. There are three of the most common types of lasers are used in glaucoma, with several more still under development. Lasers with wavelengths between 488 and 514 nanometers, of which argon is the prototype, are very good for ophthalmology due to its excellent absorption by melanin, which is abundant in the eyes. Mostly continuous wave modes are used, but micropulsed machines are now emerging, providing good thermal effects while minimizing collateral damage from surrounding tissues. Next, Nd:YAG lasers utilize its photodisruptive effects to create incisions like in iridotomy and capsulotomy. Q-switch platforms are used for selective laser trabeculoplasty. Semiconductor diode lasers with 800 to 820 nanometer wavelengths give better scleral penetration than argon lasers, but with comparable thermal and photocoagulation effects. This makes it ideal for transscleral cyclophotocoagulation. Okay, now first up is laser iridotomy. So the most common laser procedures in glaucoma are as follows. And first up is laser iridotomy. It involves the creation of a hole through the peripheral iris to connect the anterior and posterior chambers when there is a pupillary block. This allows aqueous to escape from the posterior chamber and flow onto the anterior chamber, bypassing the pupillary block and therefore relieving the angle closure. It is most commonly used for acute and sometimes possibly even chronic primary angle closure with pupillary block, depending on the status of iridotrabecular contact. If there is significant peripheral anterior synechia, laser iridotomy may not be effective. LI is indicated for the fellow eye of the patient with primary angle closure. High-risk angle closure suspects may also benefit from this procedure. Secondary angle closure patients may also benefit from LI, but the common factor amongst all these is and still is pupillary block. Now, iridotomy may also be used in conjunction with iridoplasty for plateau iris syndrome to further prevent angle closure. Now, talking about primary angle closure suspects, it is a relative indication for laser iridotomy and should be weighed carefully by the doctor. Other factors to consider for this kind of patients include the need for repeated dilated examinations, poor access to ophthalmic care, and a family history of primary angle closure. This study published online last March 2019 noted that the incidence of angle closure disease was very low among individuals classified as primary angle closure suspects identified through community-based screenings. Laser peripheral iridotomy had a modest, albeit significant, prophylactic effect. In view of the low incidence of outcomes that have no immediate threat to vision, the benefit of prophylactic laser peripheral iridotomy is limited. Therefore, widespread prophylactic laser peripheral iridotomy for primary angle closure suspect is not recommended. So for PACAS, it will be the clinician's sound judgment to whether or not do prophylactic laser iridotomy, taking into account the possible outcomes and complications the patient is subjected to. it will be very difficult to do the procedure under poor visibility. So LI is, and also iridotomy is usually ineffective in patients with significant peripheral anterior synechia. But these patients may be done with peripheral iridoplasty first to relieve the synechia prior to iridotomy. Doing LI on a very shallow or flat anterior chamber may inflict corneal endothelial damage, so it is done with extreme caution. Of course, it is absolutely important to have a complete ophthalmic exam prior to doing this procedure. But the biggest point of emphasis is doing proper gonioscopy. It goes without saying that the physician should have a firm grasp of the intricacies of a proper gonioscopy examination, including dynamic and indentation maneuvers. Again, if the patient has significant PAS, LI may not be effective. Pre-op preparations include topical anesthetics, pilocarpine to stretch the iris, and alpha agonists to blunt possible IOP spikes after the procedure. For patients with corneal edema in acute angle closure, one must break the attack first by giving IOP-lowering medications, anti-inflammatory drops, or hyperosmotics such as glycerin on the surface of the cornea to relieve the edema. Corneal indentation for about 10 minutes may also lower IOP if the iridotrabecular contact is not yet synechial. Paracentesis may also be done to quickly lower IOP temporarily and give us a short window of opportunity with a clear cornea to do the procedure. Iridoplasty may also help in deepening the peripheral anterior chamber and possibly relieve iridotrabecular contact. Now, here are some examples of lenses used for iridotomy, and I think the Abraham lens is the most commonly used here. Site selection, of course, is important, but the bottom line is one should select an area with a large or deep iris crypt for ease of doing the procedure. Try to avoid the 12 o'clock position. The procedure may produce cavitation bubbles that end up floating in this area, thereby making visibility difficult. Avoid locations where the eyelid bisects the iridotomy to avoid visual disturbances such as ghosting. There are several techniques to this. Some use argon lasers, some use the Nd:YAG laser, and some combine both lasers. Either of the lasers have their own advantages and disadvantages. Argon lasers are good for dark irises. This method reduces the incidence of hemorrhage due to its coagulative effects, while the Nd:YAG laser is the most commonly used laser for this procedure, but it is more prone to hemorrhaging. Now for argon, in general, start with a few stretch burns using low power with a large spot size and long duration to evenly distribute energy to a wide area without inflicting severe burns. Next up, use high power with small spot size and a short duration to concentrate energy on a small area to chip away at the iris. The coagulative effects minimize bleeding, but this may be time-consuming, requiring many shots to penetrate the iris. While for Nd:YAG, use high-power shots to penetrate the iris stroma. Combining the lasers often produce excellent results, getting the advantages of both types of lasers. The argon laser prevents hemorrhaging and thins the iris first. Then with just a few shots of the Nd:YAG laser, you can penetrate the iris. As always, the endpoint is the gush of aqueous and some debris anteriorly. This video I've taken from YouTube shows the combined laser procedures. The initial stretch burns were already done, and at this time, the surgeon is doing the chip burns using high power, low duration, and a small spot size to apply the most amount of energy quickly to a small area. I don't know if you can see it, but I think he's using a spot size of about 50 microns, and he is just chipping away bit by bit at the iris stroma. As I think you can observe some bubbles, cavitation bubbles arising. So they tend to float towards the 12 o'clock position. So after about 80 shots of, let's rewind that. So after about 80 shots of the argon laser, you can see a charred space here. And with just 1 or 2 shots of the Nd:YAG laser, we were able to, he was able to penetrate the iris stroma. And you can see the flow of, aqueous forward. So this is a sample video of doing the laser iridotomy using both Nd:YAG and the argon lasers. Okay. This is an example of a post-cataract surgery pupillary block showing severe narrowing of the peripheral anterior chamber. This picture shows the same patient after a laser iridotomy, relieving the block and producing a flat iris with a much deeper peripheral anterior chamber. After the procedure, it is best to check for IOP spikes up to 1 hour post-laser if you can. Do a gonioscopy to make sure that the anterior chamber deepens or there's some change in the anterior chamber. And we usually apply a short course of topical steroids. Possible complications of this procedure include bleeding, corneal burns, decompensation, lens opacities if you hit the lens, chronic inflammation, retinal damage, aqueous visceration, pupil abnormalities, and visual disturbances such as ghosting or glare. Here's a simple flowchart I devised to guide me in decision-making after doing a laser iridotomy. If the angles open up after LI, then you're quite sure it's a pupillary block and you relieved it. When the angles are still closed or very narrow, we may try peripheral iridoplasty. If the angles open up, it may be due to plateau iris or a very steep iris configuration. If the angles are still not visible, one may try lens extraction with or without goniosynechialysis, depending on the amount of synechial angle closure, or even try trabeculectomy altogether now to lower the IOP. Take note that before doing iridotomy, there should not be any significant synechial angle closure. Okay. Now, next type of laser procedure is laser iridoplasty. This involves applying thermal energy to the peripheral iris to shrink it and create space. As seen in these 2 OCTs, the left image shows a narrow peripheral iris configuration. The right image shows a wider peripheral area after doing laser iridoplasty. This is most especially effective among plateau iris patients to decrease the threat of angle closure in scotopic conditions. This photo shows an anterior segment OCT image of a plateau iris patient in scotopic conditions, with the left side showing a larger space after iridoplasty, compared to the right side, which hasn't had yet the iridoplasty. Iridoplasty may also be used to widen the angles in breaking acute angle closure and also as preparation for trabeculoplasty. It can be useful in removing an iris plug from the internal opening of a trabeculectomy site. This picture just shows a before and after image, a gonioscopic image of a patient who has undergone laser iridoplasty. Before iridoplasty, you cannot see any of the angle structures, but after LI, you can already see them. We've flattened the iris peripherally. Patient preparation is quite similar for LI, again, with particular emphasis on gonioscopy or proper assessment of the angles. Use as low power as possible to effect shrinkage of the iris. Dark-colored irises usually require lower power due to its excellent energy absorption. Use longer durations and larger spot size. Use of longer duration and larger spot sizes allows us to evenly spread the laser energy over a wider area of the iris, unlike in LI where you want to concentrate as much energy as possible in a small area. Remember to aim peripherally, almost to the insertion of the iris root, as seen in this photo. Centrally located spots have very minimal to no effect at all on the peripheral anterior chamber. These two photos showed a quite peripheral, quite central burn. So this is wrong, this is correct. Again, this is a YouTube video of argon laser iridoplasty. So I hope you can observe the shrinkage of the iris as laser energy is applied towards the periphery. See that? It's shrinking. And the surgeon is aiming as peripheral as he dares without touching the angle structures. Okay. So again, you have to check for IOP spikes even up to 1 hour post laser. You do your gonioscopy to make sure that you've achieved your therapy goals. And again, a short course of topical steroids. Possible complications are quite similar to laser iridotomy. Next is laser trabeculoplasty. It involves applying laser energy directly to the trabecular meshwork complex in efforts to change its structure and effect a lowering of IOP. The two most established types of trabeculoplasty are argon laser trabeculoplasty and selective laser trabeculoplasty, with both having their own distinct characteristics, mechanism of actions, advantages, and disadvantages. Other emerging types of laser trabeculoplasty include micropulsed laser trabeculoplasty and pattern laser trabeculoplasty. There are several theories regarding the mechanism of action of laser trabeculoplasty. The mechanical theory posits that LTP, particularly argon laser trabeculoplasty, causes tightening of the inner lamellae of the trabecular meshwork, preventing collapse and improving outflow. SLT and the other types of laser trabeculoplasties are theorized to stimulate trabecular cell division and repopulating the meshwork with healthy cells, which improve outflow. They may also trigger macrophages to remove cellular debris. The mild inflammation caused by the laser energy may trigger these effects. These are electron microscope images of the trabecular meshwork after ALT and SLT. ALT shows severe coagulative damage as compared to SLT. This illustrates the effects of both lasers on the trabecular meshwork may be different. Trabeculoplasty is an excellent option in open-angle glaucomas of these varieties, especially with pseudoexfoliation and pigment dispersion. On the other hand, it has minimal to no effects. Sometimes it can be even harmful for these kinds of open-angle glaucomas. Again, for pre-op preparation, we cannot overemphasize proper pre-operative examination, particularly gonioscopy. This procedure is only applicable to certain open-angle types of glaucoma. These are some of the characteristics of ALT versus SLT. ALT, of course, utilizes an argon laser, while the SLT uses a frequency doubled Nd:YAG laser. Of particular importance is the placement of the laser burns for each type of laser and its endpoints. Okay. SLT has apparent advantages over ALT in that it is easier to do since your target is larger, about 400 micrometers versus 50 micrometers only for ALT. Your target is practically the whole angle, so it is much easier to do than targeting just a small portion of the pigmented trabecular meshwork for ALT to avoid collateral damage. But more important is SLT offers repeatable treatments as against to just one treatment for ALT. This is a video of selective laser trabeculoplasty. Note that your endpoint is just the appearance of these champagne bubbles as you hit your targets with the laser. You cannot see any blanching or any apparent direct effect upon the angles when you do this. So it is best just to observe these bubbles as your endpoints for treatment. A short note on micropulse laser trabeculoplasty. It uses a similar argon laser as ALT, but it is micropulsed, thereby theoretically reducing collateral damage as compared to ALT. It is said that due to it being pulsed, the beladine-rich cells of the trabecular meshwork will absorb much of the energy, avoiding damage to other neighboring cells. Studies have shown its effectiveness and safety profile to be similar with SLT. And another interesting feature is its bigger spot size compared to ALT, which again makes it easier to learn and master. Also, a short note on pattern laser trabeculoplasty. It uses a computer to guide the user in giving multiple spots in one push of the pedal, similar to pattern panretinal photocoagulation. Each push produces about 3,900 micron spots across the whole width of the angle. As seen in this photo, standard ALT uses very small spot sizes, while SLT has a large spot size spanning the entire angle. PLT, or pattern laser trabeculoplasty, uses a yellow 577 nanometer laser with comparable absorption as green lasers. Studies also show comparable results with SLT. As for the methods of treatment, there is still no consensus on how much of the angle is treated every session. Most practitioners opt to do staggered 180-degree treatments to prevent severe inflammation and IOP spikes. There is also some debate over the use of anti-inflammatory medications after the procedure. As stated earlier, the mechanism of action of trabeculoplasty is inciting structural changes in the trabecular meshwork, and low-grade inflammation is a big part of it. Suppressing this with anti-inflammatories may blunt the effects of the trabeculoplasty. It is wise to do a gradual withdrawal of anti-glaucoma meds, and you have to monitor for peripheral anterior synechia. The full effect of this procedure may only be apparent after 4 to 6 weeks, hence the gradual removal of topical medications. Most studies cite a 6 to 10 millimeter mercury IOP lowering after 1 year, and success rates vary a lot. This procedure may be more effective in pseudoexfoliations and pigmentary open-angle glaucoma than your regular primary open-angle glaucomas. Both ALT and SLT may be effective in lowering IOP, so much so that some studies have shown both may be used as initial treatment for any of your open-angle glaucomas. In general, laser trabeculoplasty may be as effective as a monotherapy, and about half of patients would require some retreatment after 2 years. Its effectiveness reduces after each treatment to some degree. But it is still a very good alternative to medical therapy, especially for those intolerant of topical medications. Again, possible complications are quite similar to LI and peripheral iridoplasty. Now, next is laser suturelysis. It is done to cut one or more of the retaining sutures of the scleral flap after trabeculectomy to increase outflow of the aqueous. It is only applicable if simple permanent sutures are used. This should be done within 2 to 3 weeks after surgery, as fibrosis of the bleb after this period may be significant already, thus making suture removal ineffective. Revision of the bleb either by needling or full lifting of the flap may be more useful for severely fibrosed blebs. An argon laser is used, and you have to use high power, short duration, and small spot size in order to concentrate as much power as possible onto the suture to be cut. You use this type of lenses to press on the conjunctiva over the suture to be cut for adequate exposure. Before doing this procedure, make sure that LSI, laser suturelysis, will actually increase outflow. This means that the bleb may have minimal to no fibrosis and there is no iris plug stuck on the internal opening of the sclerostomy. You can do light corneal massage maneuvers to determine if aqueous can pass through the tight flaps. If aqueous cannot be forced onto the bleb by massaging, LSI may not be that effective. Again, possible complications of laser suturelysis include conjunctival burns, maybe even leak, hypotony if you induce very high flow of aqueous. You may also incite bleeding, and post-operative monitoring should include bleb configuration appearance monitoring and IOP leaks. IOP, and you have to check for leaks also. Last type of laser procedure is cyclophotocoagulation. It involves reducing the IOP by destroying the source of aqueous by destroying the source of the aqueous. To date, there are three approaches to this, namely transpupillary, transscleral, and endoscopic. By far, the most common is transscleral because it is easiest to perform and least invasive. It may be used for refractory glaucoma with poor visual prognosis. It's also a good alternative to evisceration or inoculation to painful blind eyes. And it can also be used for patients who refuse or cannot be cleared for incisional surgeries. Simply put, cyclophotocoagulation involves applying laser energy through the sclera into the ciliary body, where it destroys the tissues, thereby decreasing aqueous production. The most common laser used is the diode 810 nanometer wavelength laser. It can penetrate sclera better than argon lasers, and it has a comparable absorption properties as well. The micropulse type of this laser, where instead of using a continuous power delivery, it is pulsed, allowing for less collateral damage in the surrounding tissues, while selectively producing effects on the melanin-containing tissues of the ciliary body. This, in effect, reduces the incidence of complications associated with this procedure. This procedure may be quite painful, so retrobulbar or a peribulbar anesthesia is recommended. Some patients may even require general anesthesia. The G probe is aligned to the limbus, and its design allows it to more or less deliver the laser energy directly onto the ciliary body underneath the sclera. These are the settings commonly employed. You can treat more or less 270 degrees, avoiding the 3 and 9 o'clock positions, since you may hit significant blood vessels in these areas. One can even up to treat 180 degrees or less, depending on the amount of IOP lowering needed. Titrate the power and duration settings at which the popping sound occurs, then dial the power back a little. Again, this is a video of transscleral diode cyclophotocoagulation. Okay, so it is also useful to use. It is also useful to just apply lid speculum for adequate exposure, and you listen for the light pop. I'm not sure if you can hear this pop. There you go. I hope you hear that pop. There you go. Okay. So topical steroids and atropine are needed after to reduce inflammation and ciliary spasms. Analgesics may also be given since this is a very painful procedure. You have to continue IOP lowering meds and gradually reduce over time since the procedure's maximum effect is not apparent until about a month or two. Some regression may occur, necessitating multiple treatments. Some possible complications for TSCPC include pain, bleeding, phthisis, cystoid macular edema, significant vision loss, and sympathetic ophthalmia for the fellow eye. Okay, so as general tips, you have to know your equipment inside and out, including the lenses. Okay, you have to do this in order to determine its capabilities and maximize the treatment. You have no business doing iris or angle laser procedures without knowing how to do a proper gonioscopy. Proper patient communication is necessary to properly manage expectations and possible complications. The clinician should also have patience in trying to learn these techniques and applying them in practice. Some of the effects of these procedures are not apparent until several days or weeks or even months, so proper follow-ups are necessary. Now, I just added this one slide as a special slide for these times. No, so special emphasis is being given to disinfection and proper protection for both patient and doctor during these times. I'm sure all of us have already instituted measures to protect ourselves and our patients from COVID. Possibly, all institutions have already implemented screening procedures for their patients, and they are also applicable for us. Protective equipment, especially proper face masks for both patient and doctor, is now mandatory. Although these procedures are not aerosol generating, we may spend a considerable amount of time near the patient's face, especially our hands holding the lenses. We will be exposed to the patient's tears and other secretions, which may be a vector for COVID transmission. Aside from the breath shields, one may consider applying iodine solutions to the patient's eye before the case. This is similar to the ones we use for cataract surgeries. Just make sure of adequate contact time of the iodine and remember to wash it off adequately before starting the procedure. Again, it's never overemphasized. Washing and disinfection is of paramount importance these days. So in summary, okay, we have already tackled these 5 most common type of laser procedures in glaucoma: laser iridotomy, laser iridoplasty, trabeculoplasty, laser suturelysis, and some cyclodestructive procedures. I would like to say thanks to the membership of the Philippine Glaucoma Society, to Dr. Cesar Perez, Rigo Reyes, and Tori Rosario for helping up with my slides, and the PGS Virtual Roadshow technical staff for making this event possible. So these are some of my resource materials, and thank you very much for your attention.
Thank you so much, June, for a very concise and informative lecture. I think
Thank you for
are
listening.
very practical and must-knows for all of us. Okay, so before we start with our question and answer portion, I would like to remind everyone to please fill out the feedback forms posted in the YouTube and Facebook chat boxes, because this will serve as your attendance. So let us now proceed with the question and answer portion. For those of you with questions, you may still post them in the chat boxes in the platform you are watching from. Okay, so our first question is from Dr. Patricia Concepcion. So good evening, Dr. Orros. For ALT, does it really need the machine that uses argon gas? Or can a 540 nanometer argon-like laser machine same that is used in PRP be used?
Yeah, actually, yes. The answer to that is yes. What's important is the type of laser used, or the frequency of the wavelength. Sorry, not the frequency. The wavelength of the laser used. So thereabouts about 540 nanometers, 530. Some even use 532 nanometers, because this wavelength offers the best absorption for melanin-containing cells. So yes, argon-like lasers, with similar wavelengths can be used for ALT.
Okay, so we have another question here from the audience. For LI, do you do argon preparatory burns or do you just use YAG directly?
Personally, I do argon preparatory burns. Okay, but it really depends on what your capabilities are, and also what equipment is available for you in your respective eye centers. I know a lot of ophthalmologists just use they go straight to SLT to YAG lasers, but I tend to shy away from that because they tend to produce a lot of bleeding. That's why I do argon preparatory burns first. Then with just one or two shots of the NDIAG, you'll get a clean hole. You get a cleaner hole actually when you combine both procedures.
Yeah, that's right. Okay, thank you. So we have another question. So for treatment naive open angle eyes, can you consider doing SLT as first line of management before starting topical medications?
Yes, actually, you can consider that, because studies have shown already that it's actually as good as one drug or monotherapy. Okay, you can actually try that. No, uh, you can find it very useful in rural areas, where if rural areas, or if your patient cannot come to you as often as you want, or cannot does not have access to medications. Why not just try an SLT or any laser trabeculoplasty? At least you have some assurance that maybe you have some IOP lowering for your patient. But in short, yes. Yes, the answer is yes. You can use it as primary therapy.
Okay. Thank you for that answer. Our next question is for SLT, the most commonly used lens is the Latina SLT lens. But can you use the normal gonio lens if it is not available?
Yes, actually, you can use it, but it may be a little bit difficult to put confluent spots, because unlike the specialty SLT lens, you have hash marks or grid marks on it. So you can mark your spot where you had your laser treatment already, and you can just move to the next hash mark. With normal gonio lens, you don't have that. So it's a little bit more difficult to do, but yes, it is possible to do it.
Okay. Another question. Good evening. How can cyclophotocoagulation cause sympathetic ophthalmia?
Well, I've only read this in some books. Personally, I haven't seen this happen, but in some literature, they've reported some cases of sympathetic ophthalmia, because it actually involves injury to tissues. Now, I know that sympathetic ophthalmia usually occurs if you have iris or uveal tissue exposed to the air, but sometimes maybe even injury to uveal tissues, which is what we're actually doing with cyclophotocoagulation. So injury to a uveal tissue may cause, a sympathetic reaction to the other eye. But personally, I have seen this. I haven't seen this, but in literature, they've reported it already.
So from Dr. Cynthia Versosa, how long do you wait after laser iridotomy before you perform iridoplasty?
Well, actually, it depends on the case. You can even do it simultaneously if you want to. You can do it simultaneously. Um, Honestly, I there's no time frame, no, to wait to observe if you want to do iridoplasty. But if you can see that the angles aren't widening up to your liking, or you need to do repeated dilated exams for these kinds of patients, you can actually do iridoplasty right away. So it
Just
depends
one.
on your clinical judgment again.
Okay. So another question. How long after a patient has had an acute angle closure attack would you still consider doing laser?
Oh, well, yeah. Well, the answer really depends on the amount of synechial angle closure. I've been stating repeatedly already that as long as you don't have synechial angle closures, LI is a really good option for these kinds of patients. But if you have significant synechial angle closure already, I don't think LI will be effective anymore. You may opt to do a trabeculectomy already for synechial angle closure, or even or gonia synechialysis can also be done. But LI, not so much anymore.
Okay. So another question, June.
Mhm.
How long does an iridoplasty's effect last? Is it like an iridotomy which maintains its effect permanently for as long as it
Yeah.
stays patent?
As far as I know, yes, its effect stays, for a long time. As far as I know, as far as I know.
Okay. In acute angle closure, would you still do laser iridotomy even if medical management does not break the attack?
In acute angle closure, would you still do a laser iridotomy even if it does not break the attack? Well, it all boils down to, of course, again, one, visualization. If you cannot see what you're doing, it's better not doing it if you cannot see what you're doing. Um, if you're able to, it says nga if you're not able to break the attack, yeah,
Yeah.
might as well not do your laser iridotomy anymore. If you cannot break the attack, you can just go ahead to incisional procedures already, because the prerequisite for LI to be effective is if you don't have peripheral anterior synechia. So that is the key.
Okay, so another question, June. For patients with seeing eyes with high intraocular pressures on maximum medical therapy, but they cannot be cleared by their primary care physician for glaucoma surgery. So, for whatever reason, so is transscleral cyclophotocoagulation a viable option, and how would you go about it?
I think yes, it is a viable option, but of course you have to think this through. And usually you can do just one portion. I mean, maybe less than 180, even only 90 degrees of trabecular of ciliary body. You can photocoagulate as just a small portion of your ciliary body, to effect a decrease in aqueous production. So yes, it is a viable option. It is.
Uh, so another question, June. Have you ever treated a patient with iris bombay using laser?
Sorry, personally, no. I haven't seen a patient with iris bombay. No, I haven't seen one. So I cannot answer that question actually, Tori, because I haven't seen one yet in my practice.
Okay. So another question from our audience. Have you tried doing SLT in a patient with primary angle closure glaucoma whose angles have opened up but IOP still hasn't decreased? Do you think it would work?
Again, personally, no. Personally, I haven't tried doing this, yung opening up the angles to produce to do a trabeculoplasty. Personally, I haven't seen this. I haven't done this personally, but my boss back in Australia has talked about this, but I haven't seen a patient yet, and I think it's viable. I think it's doable. I think I think it may work if you think about it, the principles of your laser procedures, principles of laser trabeculoplasty. I think it can work, but personally, I haven't done it yet.
It can be more of like a mixed mechanism, no?
Yes. Mm-mm.
Okay. So, if there are no more questions, let me again thank Dr. Orros for giving us an excellent lecture. Thank you for your time and knowledge that you have imparted amongst us. At this point, let me call in the Assistant Marketing Manager from Santen, Philippines, Ms. Jennifer Ramirez, for a few words.
Okay, so again, Jennifer Ramirez, Assistant Marketing Manager from Santen, Philippines. Good evening to all the ophthalmologists who are now watching the part 4 of the PGS glaucoma round entitled Lasers in Glaucoma. So, in behalf of Santen, we humbly acknowledge and thank the Philippine Glaucoma Society, its officers and members, headed by President Dr. Manolet Delfin, for this opportunity to partner with you through this digital medical platform. So, thank you for your trust in Santen. And also, special thanks to our speaker for tonight, Dr. Justo Manuel Orros, for an informative and enlightening lecture. So at this moment, we're still unsure when this pandemic will be over throughout the world. But one thing is for sure, Santen Philippines will remain to partner with the medical thought leaders for more stimulating topics, if only to support your continuing medical development and also help contribute to giving your patients the best vision experience and deliver happiness through vision. So with that, thank you and enjoy the rest of the evening.
Okay, so thanks again to Santen Philippines for supporting the Philippine Glaucoma Society's activities. We hope to work with you again in the future. Now, to give us our closing remarks, let me call in the PGS Vice President, Dr. Hannah de Guzman.
Good evening, everyone. We called this series of webinars the PGS Virtual Roadshow because our members used to travel to various provinces to deliver our lectures, hence the use of the term roadshow. I hope that our audience has benefited from tonight's very practical and informative talk by Dr. Oros, as well as from the previous 3 webinars. Until we are able to resume uh, going back on the road to conduct face to face teaching activities, the PGS is planning more online learning activities, so I hope that you will continue to join us in the future. Many thanks to everyone who has made tonight's webinar as well as the entire series of webinars possible. I would especially like to thank our speakers and all the PGS members who have helped produce the live streams. And of course, thank you to Santan for their continued support of PGS activities. So good night, everyone, and thank you once again.
Thank you, Dr. De Guzman. And we hope to see everyone at the PGS pre-recorded sessions for the PAO Virtual Annual Convention from November 14 to 26. We have a very exciting list of lectures lined up for you guys. We will be tackling on SLT, AI, and glaucoma management during COVID times. And on our live session on November 27, we will be talking about surgical options in the management of glaucoma. And so all good things must come to an end. So we formally bring this session to a close. I would also like to acknowledge our IT team composed of newly accepted members to the PGS, Doctors Jet Rael and Paul Gomez, and handling the PAO side, Dr. Roel Villanueva. Again, for those who missed the 4 sessions, you may watch them again on PGS YouTube and PGS Facebook page. Thank you to everyone for watching the last lecture of our PGS Glaucoma Roadshow. We hope We learned a lot. Have a great rest of the evening and stay safe.